And share my slides, and then we'll go ahead and get started. All right, can you guys see my screen? Perfect. Okay, so we will go ahead and get started while people start trickling in to be respectful of everyone's time. So thank you all for joining us today for our quarterly webinar on increasing access to cancer screening through mobile and HPV self-collection. So we have a really good group of speakers today that are going to share some great insights, data, and best practices for this topic. So thank you all for joining us here today. And we are going to jump in. So here is our agenda. So I am just going to start off real quick with a brief overview of Huntsman Cancer Institute and the Office of Community Outreach and Engagement. And then I'm going to pass it over to Abby, who is from the American Cancer Society, to be our key speaker on mobile screening and bringing care to communities. And then we'll cover some community spotlights from Utah and Nevada. And then we will transition over to Dr. Deanna Kepka, who is going to talk about HPV self-collection. And then we've reserved some time at the end for questions, and then a post-webinar poll. So a brief overview of Huntsman Cancer Institute for those who may not be familiar with our work. We are the only designated National Cancer Institute designated comprehensive cancer center in the region. So you can see here we serve the states of Idaho, Montana, Nevada, Utah, and Wyoming. So we serve a really large landmass, which is about 17% of the US landmass. And of these states, we serve about 10.3 million people. That includes 43 American Indian tribes and nations and over 35,000 annual cancer cases. And then our office specifically, which is where this webinar stem comes, is the community outreach and engagement. So our mission is to collaborate with community partners, patients, advocates, clinicians, researchers, and students to address unique cancer-related challenges. So again, we do serve 5 states, so we have a really large catchment area, but with that comes our focus areas, which include building partnerships with other community-based organizations, enhancing community awareness and education, improving access to care, and driving long-term data-driven solutions. So good to meet you all. We have some folks from our team here, and thank you for joining us here today. And then with that comes, again, partnering with communities. So our office really strives to connect research, care, and communities across the Mountain West, which is those 5 states that I mentioned earlier. And we really try to center our work on listening to community voices first, building trust, and then supporting community-led approaches to prevention, education, and care. And then with that comes one of our programs, which is the Mountain West Cancer Collaborative. This is a group that hosts these webinars quarterly. So if you are new here and are not part of the collaborative, we invite you to join. Again, we do have quarterly webinar series on different topics. We send out newsletters. We have ad hoc action groups. So you can scan this QR code to join and get more information about what we're doing at Huntsman. And then we also work with our partners across the other states as well. So we invite you to join us and be in the loop of the work that we're doing. Awesome. So to transition to the webinar itself, so the objectives for today are to highlight innovative approaches to expanding cancer screening and access, including mobile and community-based screening programs, share practical examples and lessons learned, and then also explore emerging prevention strategies that includes HPV screening programs to increase participation in cervical cancer screening. And then with that, I just wanted to highlight real quick here in the state of Utah, a policy update. So this bill recently passed that is relevant to this webinar today, but it will require Utah health insurance plans to cover mammograms performed by approved mobile mammography units operating in rural areas. So we're very excited for this and for the access that this will expand to those that live in rural areas in Utah. So with that, we are going to kick off the webinar with our first speaker, Abby. I will read her brief bio and then pass it over to her. So Abby is the Director of Implementation Collaboratives at the American Cancer Society, where she develops and manages pilot initiatives designed to strengthen connections between primary care and specialty care to improve the quality of cancer care from screening through treatment. She supports project implementation by guiding the collection and analysis of baseline data and works closely with staff to develop materials, tools, and resources for the projects that she oversees. So with that, I'm going to pass it over to Abby to kick us off.
Excellent. Well, thank you so much. So again, my name is Abby Moeller. I'm the Director of Implementation Collaboratives in our Implementation Science Department with the American Cancer Society. If you want to move on to the next slide. The American Cancer Society exists because the burden of cancer is unacceptably high, and I think we all have a role to play in ensuring that that does not continue on. Our vision, if you go to the next slide, is to end cancer as we know it for everyone. We really want to improve the lives of people with cancer and their families through advocacy, research, and patient support to ensure everyone has an opportunity to prevent, detect, treat, and survive cancer. So that is really where we hang our hat on the work that we do, both in our patient support pillar and within our advocacy, which I see you all are supporting cancer advocacy as well. So that's excellent to see. If you go to the next slide, I have a little bit of data just on our national burden of cancer. And with the 2024 report that this came from, we are going to see over 2 million new cases of cancer per year, which will estimate in about a little bit over 600,000 new deaths per year. We are seeing that mortality rate go down, thankfully, because of our screening modalities and the work that we're doing to increase screening rates. So if you go to the next slide, we understand obviously how important cancer screening is. And this is just really talking about why screening matters. When cancer is detected early, it's much easier to treat. Screening and prevention efforts have helped avert nearly 4.75 million cancer deaths in the US since 1975, and we've added 12 million years of life over the past 25 years. So thankfully, with the work that we're doing around cancer screening, we are really seeing some great impact from that. If you go to the next slide, although we have screening guidelines and modalities, there are still quite a few different barriers for patients to get the care they need. The barriers aren't necessarily about patients' willingness to get screened, it's really about access. So again, when we delay those screenings, it leads to later stage diagnosis, higher treatment costs, and lower survival rates. And the barriers, again, don't have to do with willingness, they're really about access. So things like transportation challenges, lack of nearby screening facilities, an inability to get time off of work and childcare responsibility, as well as healthcare deserts where there are, humongous distances between homes and where healthcare can be provided. And so, really, when we look at these barriers, they're disproportionately affecting those in rural populations, in underserved urban communities, in low-income populations, and again, in communities of colors. And so, really, mobile screening programs were designed to meet people where they are so that they can bring life-saving services directly into communities. So, that's one of the major things that we can see as a solution to some of these barriers. If we go to the next slide, great. So this is a tool that American Cancer Society has developed called the Screening Disparities Atlas, and I will make sure that you have the link to this. We have built this tool to help us really get a closer look at some of the screening disparities across the country. You can zoom in on your areas and get additional information about what impact those disparities are having on your cancer screening rates. We see that many times the counties with the highest cancer mortality are also those with the lowest screening rates, and where rural and low-income communities face the largest barriers to screening access. So again, I know many of you are in either rural or frontier areas, and so would love for you to take a look at some of these areas in the screening atlas and again, really zoom in to see where there are some data-driven decisions that you can make about screenings that are very relevant to your populations. So when we look at some of these screening disparities, and when you're looking at rural versus urban, rural residents are about 14 to 27% at lower odds of being up to date on their breast cancer screenings. So again, really needing to work hard to get the screenings to where people are at and decrease those barriers that are getting in the way of getting people screened. When you look at colorectal cancer screening, it's a screening rate of about 74% in a rural area versus urban is a 77%, almost 78%. So we're looking at, about a 4% difference. Then when we're looking at cervical cancer, and I know we're going to talk a little bit about at-home HPV screening, and so that's something that will definitely help with this. But there's an overall decline in screening in the rural and urban areas. That gap has been narrowed a bit, but again, overall rates have still fallen. So, and then when you look again at some of these structural barriers, only about 5% of oncologists practice in rural areas, despite a 15% population of those available. And there are some unexplained barriers as well. So 72.5% of rural urban colorectal disparity is unexplained by known socioeconomic factors. So there's some things coming into play that we're not really sure about. So I think continuing again with navigation with your patients and really finding out what are the barriers that are holding back or causing hesitation with your patients outside of some of the well-known ones that we've talked about before. So if we look again at rural and frontier specific, distance to care is a major barrier. So again, data from American Cancer Society and the National Cancer Institute show that many rural patients have to drive about 30 to 60 miles to reach cancer screening services. So that is, when we're talking about barriers like childcare and time off, we're talking about a whole day off to be able to get into the facility, get the screening done, and get back home. Some frontier communities require 2+ hours of travel to reach specialty care. So again, that travel burden is going to lead to the delayed screening, missed appointments, and lower follow-up rates, which again are so important. So, geography really determines whether someone gets screened. And so in the next slide, we talk again a little bit more about, how we can overcome some of these barriers. So let's think about screening like a pyramid. At the top are the people that have full access. They can easily get to clinics, they have insurance, they're up to date with screening. And in the middle, we have sort of this partial access where people face some barriers, but it might miss screenings, but it's inconsistent. At the bottom are communities that face the most significant barriers. So again, we're talking rural populations, uninsured, historically underserved groups, and this is exactly where the mobile screening is going to make the biggest impact by bringing that care directly into the community. So something that can really be a solution if we have access to the ability to do some of these mobile screenings. If you go on to the next slide, I think, many times when we think about mobile screening, we think about mobile mammography units. And so that's, again, sometimes the most popular one. However, we're really getting sophisticated in the ability to do additional screenings with mobile units. So lung cancer screening, now we have some low-dose CT scanning that can be done on a mobile machine. Cervical cancer, we've now got mobile HPV testing, but also can possibly do some at-home testing as well. When we talk about colorectal cancer screening, it's a really cool idea to bring fit stool testing or Cologuard out on your mobile unit and can possibly do some multi screening methods all on with one mobile unit. Super important though too is to keep in mind that navigation to colonoscopy. So if we have a at-home test that's positive, ensuring that we reach out to that patient and are able to get them into colonoscopy, or those who maybe would not be eligible for a FIT test, getting them to a facility to get that colonoscopy done as well. These programs, again, really help address some of those structural barriers like transportation, distance care, and limited clinic availability. So, again, mobile screenings are such an important tool to overcome barriers that are impacting rural and frontier patients. And so, it's really important to bring screening to them in places where they live or visit. And there's so many different mobile options that are really available to bring those again right into the community. So again, we also have at-home screenings. And so many times we can have a conversation with a patient and send them right to their homes. If there is a way to, again, get them sent out and get the labs, get their results back to the lab. So there are things like stool tests for colorectal cancer, self-collection for HPV tests, and then again, that telehealth. That's a great way to start to do some education and some conversations with your patients to help them really get through the screening process that they might need or might be eligible for. It can remove many access barriers and again, hours on the road for some. It reaches individuals who might not engage with healthcare systems. So again, many times you can do a touch-free screening if you're able to just send that kit right over to them. They complete it and send it right into the lab. Supporting strategies, and these are really, really important, are patient navigation. So again, just ensuring that the patient understands the full process of the screening and any follow-up that's needed, and that they have access to any follow-up that's needed should they have a positive at-home test or need additional follow-up care. Community health workers are a great way to have conversations right within the community to get some of that education and awareness in front of the community members who really understand what their barriers and maybe hesitations might be. Different education campaigns. Again, knowledge is so important in understanding the guidelines and how the whole screening process works to decrease some of that hesitation. And then again, partnerships with community organizations. These can be places where your community members and patients are going to. It could be a place where mobile units could also park to be able to do some of those screenings. And so I think just really getting a great understanding of your community members and your patients' needs helps in partnering with some of those organizations. In the next slide, we have worked with quite a few projects across the country who have done mobile screening projects or have started up mobile screening or enhanced their mobile screening. And so some of the best practices that we have seen are, again, that multiple screenings provided with one mobile unit. And many times that means bringing a FIT test or Cologuard or at-home screening kits on their mobile unit. So as they are doing, whether it's a mobile mammogram or mobile CTs, they're able to then distribute those kits as well to either their patients or to family members. So sometimes it's doing some community outreach and education that those will be available while that mobile unit is at a community organization or at a screening facility, and just inviting people to come and grab those as well. Providing transportation to the mobile unit. So this is thinking, wait a minute, isn't the mobile unit supposed to overcome that barrier of transportation? But sometimes people still have a ways to go to get from their neighborhood to that mobile unit. And so possibly providing some transportation to the mobile unit. I've also seen it where the mobile unit is at a community organization and they will have transportation from a FQHC or a clinic or a hospital to where that mobile unit is at. So again, you're going to the places and helping them get to that mobile unit, just again to decrease any additional access or transportation barriers. Easy scheduling, that's a huge best practice. So if you are able to easily send out a text message where you can schedule right from there or get online and do some scheduling or rescheduling, that's another best practice. So we've seen that happen as well. The easier it is to schedule and reschedule, the more accessible it is for the patients. Bring a friend. And so many times there'll be a screening event. And so if you bring a friend who is also screening eligible, that's a great way to increase the number of patients who you see in the day. Ensuring the mobile unit is accessible for all. So many times with mammograms, the seats aren't necessarily wheelchair accessible. And so we've seen where people have made enhancements to their mobile unit to ensure that wheelchairs are able to get onto the unit as well as adjusting the way that the mammogram unit is able to get to people who are in wheelchairs who need that screening as well. Again, follow-up care is crucial and ensuring screening is wonderful, but if you're not going to do follow-up or you don't have a way to easily have that person access follow-up care, it's just so important to make sure that they're able to do that. Again, that partnership with community-based organizations to have places to not only get education out and awareness of where the mobile unit is going to be, but also to possibly be able to use their facilities to have your screenings done on site. Different screening days, and so partial mobile, partial in clinic. So we've seen days where the mobile mammogram unit is in the front of the screening facility, and then people can go inside and get their PAPs done. So like a women's screening day where you can get both your mammogram and your PAP done in one day, where partially it's going to be done at the mobile unit, and then you can walk right into the clinic and have that additional screening done there as well. Building relationships with community members and community health workers is so important too, just to, build that trust within the community. And on our last slide, this is a really cool collaboration that happened with Huntsman Cancer Institute and the University of Utah, as well as Nevada Health Centers. And they worked together to bring breast cancer screening services to women in rural communities. This was really cool because they met at the border of Utah and Nevada. And so they talked about cancer has no borders. And then women ages 40 and older were able to get walk-in mammograms. So what a cool way to not only provide additional access to these screenings. And they did obviously some education. There's the cool lung and the colon that they had a big day around this, and then overcame some of those transportation issues as well as being on the border. So people from both states were able to access that as they kind of sat right on the borderline. So really cool way to both educate and share awareness and overcome some of those barriers right there where you all are at. And I am happy to take questions if anyone has them
Awesome.
for me.
And Abby, we will do questions at the end. So if
Okay,
anyone does have
great.
questions, just hang on to them and then we'll have a little Q&A at the end.
Thank you.
Okay, awesome. Well, thank you so much, Abby, for setting the stage and providing an overview of the national burden of cancer in the United States. And I think the Cancer Has No Borders event in Wendover is a great example of how we can bring cancer prevention and care directly to communities. So building on that idea of expanding access to care, I'd like to introduce our next speaker, who is going to be our first community spotlight speaker, Marie Nagata from the Utah Breast and Cervical Cancer Screening Program. So Marie has worked in public health for over 30 years. She currently is the program manager at the Utah Department of Health and Human Services, overseeing the breast and cervical cancer screening program, the comprehensive cancer program, and the Health Resource Center. Her focus has always been ensuring everyone has equal access to care. So Marie, I will give the time over to you.
Thank you, Leslie. Today I'm going to focus on the breast and cervical cancer screening program, but I think many of the same barriers that we talk about in breast and cervical are also the other screening, such as lung and colon. We have the same barriers in Utah, so it'll cover all the variety, but we'll focus on breast and cervical today. Go ahead and change. So I am focusing on the breast and cervical cancer program, which is a CDC-funded MWCC EDP program. We serve those who are less than or equal to the 250% poverty level, uninsured or underinsured. And for cervical cancer screening, we do ages 21 to 64, and for breast cancer, ages 40 to 64. And our goal was to provide screenings, diagnostics, and treatment referral to services for low-income women. Next slide. I want to give you just a basic picture of Utah. So Utah is made up of 29 counties, and 75% of all individuals in Utah live what we call the Wasatch Front, which are 4 counties right at the top. So if you see Davis, it says Davis and it's white. That is one of the 4 counties. So it's Weber, Davis, Salt Lake, and Utah County. 75% of all individuals live in those 4 counties. So the rest of the 26 counties, 25 counties, are all considered rural in Utah. So a lot of spread and difficulties getting screening access because of that. Next slide. So I wanted to show you where we are in screenings. Utah has always been historically one of the lowest in screening for mammograms in the country, and we have been working very hard to make a change in that. So partnering with all the mobile mammogram vans and health facilities that have mammography, we have been working to bring up our screening rates, and we're very excited in 2024 that we are now making that upward slope again, and just above 67% of all women received a mammogram in the last 2 years. And this is BRFSS data, not specific to the program. Next slide. We are still on the decrease with cervical cancer screening, also one of the lowest. And so in 2020, we were about 63% of all women have had a cervical cancer screening in the last 3 years. So a lot of work to be happening. Excuse me, not just rural, but also urban. But in general, we have difficulties getting our screenings done in Utah. Because of that, we have added in 2026 questions to the BRFSS survey asking why individuals are not receiving their cervical cancer or breast cancer screening, and we're excited to get that data so that we can use that a little bit better to make some changes and promote screenings in Utah. Next slide. This shows specific to our program and where we are screening. So we are screening closer to the balance of the 75% in the urban areas and the 17% in the rural areas, which is a balance of what we're seeing, with the 75% of all individuals living in the urban areas. We still have a lot of work to do in both areas, but specifically with the rural areas. So we're at 17% there. Next slide. So what are we doing and how are we screening? We work with 5 of our 13 local health departments to do screenings, and they do screenings directly at their local health departments. We also work with our federally qualified health centers and several community clinics to do screenings. That is where our low-income individuals go to get their care throughout Utah, and then as well as all the facilities, and of course our mobile mammography vans. We're fortunate to have 5 mobile mammography vans in Utah, and So we have one that is based in the southern Utah area that sees women in that southern area. And then both the Huntsman and the Boob Bus travel throughout the state to screen women in the rural areas. Next slide. And then as Abby mentioned, our mobile mammography, one of the Huntsman mobile van is going to start HPV self-collection on the van, which will, I think, help in many areas, both rural and urban. What we find is women who are going to a male provider prefer not to be seen by them to get a cervical cancer screening. We also see that in the rural areas, they may be a relative, a friend, a faith-based leader, and they don't feel comfortable getting mammograms or cervical cancer screening from individuals that they know. And so they just go without that screening. And so we're hoping that with the mobile mammograms now being able to accept any insurance when they're in that rural area, that will alleviate some of the issues that we've been seeing in there. We also work very closely with the Office of Primary Care and Rural Health, and they're helping work with the individual providers that are in those areas to help increase screening. We talked a lot about screening with them individually and as a group. We have the Rural Health Association of Utah that we work with closely, who is also introducing cancer screenings a lot more into those rural doctors. And then the Rural 9 Network, which is a group of individual hospitals. They're not associated with any of the big hospitals in Utah. The Rural 9 Network, a lot of them do not do screenings in their hospitals, but maybe partnering up with the mammography units or finding different ways to work with them. We're working on some avenues through that network also. And the last thing was what Abby mentioned at the end, where we have bordering towns that are seeing individuals and like Wendover, they don't really have a lot of access to care in Wendover, either Utah or Nevada. So it's really great that we can come together and work together in those neighboring communities like that are on the border and work together as a partner. We have that down in Arizona with the Creek Valley area and a couple of other areas. So it's just really great to have those partners in other states that we can do the work together and make a difference. Next slide. And we'll do questions later. So thank you.
Awesome. Thank you so much, Marie, for giving us an overview of Utah and all of the work that has been done and will be continue needing to be done to increase our screening rates. So we appreciate you sharing your examples and kind of along the lines of community spotlights. I'll transition it over to our next community speaker, who is Carrie Harrington. So she is going to talk about another example to increase cancer screening from the perspective of the state of Nevada, which is another state that Huntsman Cancer Institute serves. So to read Carrie's bio, she has dedicated more than 25 years to building and leading organizations that protect and improve the health of the people of Nevada. For the past 13 years, she has served as executive director of the Nevada Cancer Coalition, the organization's first full-time role. Under her leadership, the NCC has grown into a dynamic statewide team of 8, working with healthcare partners throughout Nevada to build programs for cancer prevention, early detection, and survivorship, and to change policy to improve access to care for all. So, Carrie, you are up.
Awesome, thank you. And you can go ahead and skip to the next slide. Thanks for having me. And similar to many Mountain West states, Nevada has a vast rural and frontier population with residents often having to travel, as you heard Abby share, here 45 minutes to almost 3 hours in some areas for cancer screenings. So further, the majority of our counties, be them rural or urban, are considered health professional shortage areas, We are lucky to have one mobile unit. You saw that picture in Abby's presentation. That's the Mammo Van. They're operated by one of our federally qualified health centers. And this mobile unit services the entire state, which is no easy endeavor, especially in the winter. And it also makes scheduling your yearly mammogram very difficult. Where our two major population centers are Clark County down that kind of bigger blue dot. So that's your Las Vegas area. And then the smaller, big light blue dot up there is the Reno, Sparks, Carson City area. And then the rest of us live across the state. So next slide, please. Thank you. So at the Nevada Cancer Coalition, and we are the coalition of partners that provide care, we do not provide direct care. So we truly really upped our outreach and education game since COVID. We secured the inflatable colon, that's Colin, the colon in the north, Larry the lungs in the north as well. And then we have a similar set in Las Vegas for Southern Nevada. So we were showing up to as many events as we could across the state. We were providing information and education to thousands of people and helping them navigate to screening somewhere. By providing resources where we could. However, outreach alone wasn't cutting it. It was difficult to measure success, and we didn't know who of those people we met, the thousands of people we were meeting, if they were actually getting screened. So we set a new rule: no outreach without a service, without a screening available. The Mammo Van is an obvious partner for us in our quest. But what about the other screenings? Because again, we have one mobile unit in the state, that's it. So how does this work without a mobile unit? Next slide, please. Well, we've named these pop-up events, essentially direct services popping up where people live, work, play, and gather. It's a little more challenging when not in a clinical setting, but it is not impossible. So it's not your typical health fair, although we do provide these at health fairs, particularly in our rural communities. You can see some of the settings that we've been to. We've got a baseball stadium in Northern Nevada I'll talk about a little bit. YMCAs and disparate community areas are fantastic. People are there all the time. Churches, grocery stores, cultural festivals, etc. And we're looking for new locations too. So next slide, please. All right. Pop-up events. What are the cancer screenings? So the Mammo Van's an easy one for mammograms. However, sometimes it's just having a local provider of mammograms available on site to talk to people and make appointments. Fit kit distribution you heard about for colorectal cancer screening is a great one. For lung cancer, we've actually piloted having a healthcare provider on site that can administer the shared decision-making visit. So talk to people about those lung cancer screenings and going through that visit that's required before you can get a low-dose CT scan, and then scheduling people for those scans. Skin checks, one of our favorite, we'll talk about a little more, and then oral cancer exams. It's also becoming a favorite of our local dentists. It's an opportunity for them to get out into their respective communities and meet people and provide services. Some of the other services we've had are vaccinations, enrollment into the Nevada Breast and Cervical Program, navigation, we're navigating people to primary care, to any financial options, tobacco prevention, and I'm sure there's other services we could provide. And next, please. All right. So one of our faves, and probably the first one we started with, was a community skin check clinic, and we hosted this. Actually, our mayor was part of this a couple years ago now at the local baseball stadium, either on a weekend or after work hours when people may or may not be going to a baseball game. We have dermatologists that have volunteered their time. Med students from the local university love these because they get to shadow a dermatologist and learn about doing skin checks. We always provide navigation to follow up and financial assistance for the uninsured. So in the 3 community skin check clinics that we held last year, one at the baseball stadium and then at 2 different YMCAs, we had screened 374 people, and we found skin cancers at these events. What else was I going to mention? These are pretty easy. Skin checks take little to no time. I think it's about 6 minutes per skin check. We just set up stanchions in various locations and a doc in each one, and it goes pretty quickly. So we're able to screen a lot of people. All right, next slide, please. Oh, one of our other favorites. I think they're all my favorite. So Father Edgar, who we love, leads the congregation at St. Peter Canisius Church. He saw an advertisement for our coalition's navigation to screening service. He knew many of his parishioners likely needed help to access healthcare. So he reached out to us to bring a pop-up to his church. So in partnership with one of our other fabulous FQHCs, we planned this pop-up on a Sunday in their church parking lot. So it presented an opportunity to leverage the endorsement of Father Edgar, who's kind of a hot shot in the Spanish-speaking area, and helped us advance health equity by reducing structural barriers, out-of-pocket costs, using patient navigation, education, etc. ICE was just starting to make their visits at this time, so we think we might have been able to have more people, but we had over 1,000 people attend. And you can see the services that were provided there. And then I'll jump to the next slide. By the way, I didn't mention early on, but when we shared this idea of pop-ups with our community partners, they were all very excited and bought into it. Our for-profit, our nonprofit, again, without mobile units or clinic locations, this is a way to do this in the community without that. You don't always need a clinic. Okay, MBA Total Health Fair. MBA was one of our partners in this event, which made it a little easier financially, but we brought together 15 organizations. One of the local for-profit hospitals even came to do that lung cancer shared decision-making visit that I mentioned. The mammo van was there. Again, the skin cancer screenings with our dermatologists volunteering and the local med students. Oral cancer screenings. Interesting one, right? Local dentists were ecstatic to do this. So they showed up on a Sunday and provided these screenings. The other winning piece, and at some of these community events, we've noticed that having groceries or food available is another draw for people in the community to come out. So some other options to consider. And the next slide, please. Our lessons learned. So very interesting, but we've learned that insurance coverage alone does not ensure access to preventative care. We've seen many individuals both call us and come to these events who were insured but reported confusion about how to use their benefits for cancer screenings, where to go, and how to get this done. So there's a gap in insurance literacy, and we've noticed that is a significant barrier to getting people screened and completing their screenings. Obviously, services directly delivered on site have more engagement and completion. So mammography, that's done. Vaccinations done. The skin checks done. Oral cancer screenings done. The screenings that required follow through definitely lowered completion, and we're struggling with that a bit. The in-home fit kits for colorectal cancer screening depend heavily on a robust reminder system, follow-up infrastructure, etc. In addition to those screenings we might have scheduled on site, they require the same effort to get people to actually complete them. So there's a lot more work involved in those screenings that we can't actually complete on site, but important to do nonetheless. You have to have options required for positive findings. We can't just screen people and say, hey, good luck out there. We've been very lucky that our providers, many of them have offered to provide pro bono care to those needing follow-up care or a skin cancer addressed, for example. So those are just some of the things we've learned, and we're working to improve our pop-ups moving forward, expand our partnerships to offer more services, and really work to increase our screening uptake across the state. So mobile, a little different than the mobiles with wheels, but nonetheless, it's being in the community where people live, work, and gather, and increasing access. So thank you.
Awesome. Thank you so much, Carrie, and to all of our speakers for the first part of this webinar, both traditional and non-traditional, for sharing data, best practices, and some implementation strategies for bringing care directly to communities through these programs. So with that, we are going to transition over to the second part of this webinar, which is with Dr. Deanna Kepka, who is going to explore the opportunities for cancer and cervical cancer elimination. So she will share some insights on cervical cancer incidence and mortality and emerging approaches such as HPV self-collection. So Dr. Kepka is a Huntsman Cancer Institute investigator and a professor in the College of Nursing at the University of Utah. She is a member of the Cancer Control and Population Sciences Research Group. She leads the 500-member Mountain West HPV Vaccination Coalition and is the Director of Global and International Health in the College of Nursing. She is a tenured associate professor in the College of Nursing and again an investigator here at HCI with expertise in community-level cancer prevention and control research among underserved communities. So Dr. Kepka, we are excited to have you.
Thank you so much, Leslie. Can everyone hear me okay?
Yes.
And I'm now the past Global Health Director for Nursing, but the new Global Health Leader for Huntsman Cancer Institute. So if you have any global health interests, please talk to me. So I'm here to talk to you about new opportunities for cervical cancer elimination. We've had some exciting advancements over the last few years. Next slide. A little bit about my research. I've been working in HPV vaccination since around the time the vaccine was approved, and we are celebrating the 20-year anniversary of the HPV vaccine right now. So really exciting to see this journey, and it's been such an absolute pleasure and just the most invigorating and stimulating job to work and try and get shots in arms. I find it to be incredibly fulfilling because I know with each shot in arm, we're doing good, and that feels good. I work in other HPV cancer prevention too, oral pharyngeal, anal, penile, vaginal, vulvar. I also work in cancer health disparities and global oncology. I have the most fantastic team. And so none of this is done by me alone. There's a large group of us with partnerships all around the US and the world. And I'm really excited that my son has been a huge champion of my work too. You could see him there on the, the mammogram bus with me after he got his HPV vaccine. Next slide. So in 2030, the World Health Organization launched an initiative to eliminate cervical cancer. Any person working in cancer, any person who's been affected by cancer would be over the moon, overjoyed with the possibility of eliminating their cancer. This challenge is hard for many, many countries to meet, including high resource countries such as the United States. But a few countries are working towards it and are doing a really good job. And we hope that we can also join the ranks, even if it isn't as a country, but as a state or as the Mountain West, to eliminate cervical cancer. How can we do this? So this is one of the cancers where we already have the tools. Some other cancers are still trying to figure out how to eliminate it or prevent it, but we know what to do with cervical cancer. So our challenges are around implementation, and they're around receipt of the services that we know that work. Globally, we need 90% of girls vaccinated. In the US, we need boys and girls vaccinated at 80% by the time they reach late teenager years. We need 2/3 or about 70% of women screened twice per life. In the US, we look at intervals that range between 3 and 5 years, and 90% of women treated with precancer to prevent progression to invasive cancer. Next. We have seen a decline in cervical cancer incidence and mortality in the US with the implementation or the integration of Papa Nicolau testing in the 1950s. This has been a game changer that many other countries have yet to be able to adopt because of poor health infrastructure, lower socioeconomic status. But even so, in 2025, we had 4,000 preventable deaths due to cervical cancer in the US and 13,000 cases. And these figures are disturbing because, as I said, this is a preventable cancer, but they also don't capture the hundreds of thousands of precancers that would be prevented with HPV vaccination and early detection. Next. Cervical cancer disproportionately affects certain populations with higher rates among Native Americans, Alaskan Natives, and Hispanics. African Americans, Blacks, we see disproportionate, but it doesn't mean that every single ethnic group is at risk for cervical cancer and HPV as the most common sexually transmitted infection. But we see these inequities that largely relate to access to preventive and early detection services. We also know that there's higher rates of cervical cancer in rural communities. And in Utah, we've shown higher rates of mortality due to cervical cancer in rural compared to urban communities. In a paper that was put out recently with Dr. Mia Hashibi, maybe like a year or two ago. Next slide. So why is vaccination so important? Well, vaccination is important because you want to prevent persistent HPV infection. And to do that, you need your body to develop the immunoenergy to fight that HPV before sexual debut. The highest incidence of HPV is going to be around the time of sexual debut, which in the US averages in the late teens. And then if you aren't protected against HPV and you are infected in the late teens, that infection could progress to precancer and cancer. And that's where you see above but most people clear the infection, but some don't. And then you see it progressing in between these stages. There's many cofactors that influence progression, such as if you're immunocompromised, if you are a cancer patient, if you're HIV positive, if you have other STIs. But regardless, we don't even want to get to the point where we're at this pre-cancer and cancerous stage. And we could prevent that with early detection and even prior to that, vaccination. Next. So I'm going to talk a little bit about the Mountain West region, which, as Leslie mentioned, Huntsman Cancer Institute serves 5 states in the Mountain West. Most of my work has been done in Utah, but I'm looking to expand our HPV self-collection projects to other states in those 5-state region and in the Northwest. Next. We see in the Mountain West, you look at all of those red states, wow, this is very low Pap testing. And Marie did a great job of showing that Utah's got a lot of room for improvement. But it's not just Utah, it's Wyoming, it's Idaho, it's Montana. There's a lot of room for improvement across the whole West. You don't really see, even Nevada, you're a little bit better than us, but I wouldn't get so excited because you're, second from the bottom quintile. So we are not doing what we need to do to get women up to date with cervical cancer screening. Next. Why are women not up to date? Well, these social determinants of health can be pervasive, and they can be particularly challenging among rural communities, among communities of color, low socioeconomic status communities. If you're a mom with a lot of kids to take care of, who's the last one in line for preventive medicine? It's going to be the mom. Even myself, it's like, wait, I think I forgot to get the second dose of, so it happens that prevention takes a back seat to urgency. Prevention as a parent or as a woman often takes a back seat to the needs of others in our household. And then there's additional challenges that can rise to the top as being more important than carving out time for cervical cancer screening. Next. So In the last few years, we have had approval of an HPV self-collection kit. And that HPV self-collection kit is testing, it's being used as a primary HPV cytology, a primary HPV testing device, and versus cytology, which is a pap test. And so these are the guidelines that we're looking at. We have a little bit of conflict between the three guideline making institutions, but for the most part, we're moving towards what we're seeing for ACOG and U.S. Preventative Services Task Force, which is HPV self-collection being treated as HPV testing and occurring at the start of age 30. So high-risk HPV testing. ACS recommends that you could start at age 25. And I think that's really exciting. And in some of our primary and preliminary research studies, we have used 25 as our guideline. But I know, for example, Marie's program, they're using 30, correct, Marie? So the guidelines that we're using at the larger institutional and policy level are age 30 for the breast and cervical cancer screening program and for insurance reimbursement. Next. So cervical cancer screening is a process. So if we're going to be implementing HPV self-collection, we need to be prepared for 10% positives. Then we need to be prepared for how we're going to treat those positives. And there's different pathways for the way we treat it. So high-risk HPV types 16 and 18, immediate referral to colposcopy. The other HPV types that are cancer-causing but not 16 and 18, the referral process may be repeat, HPV self-collection in 1 year, or cytology, and then refer for treatment following colposcopy after, if within the 16 and 18 colposcopy tests, there is a need for treatment. And this is helping us to move towards early diagnosis and improve cancer outcomes. Next. So HPV self-collect, it's a lot like using a tampon in the vaginal cavity. This Copan swab is the one that I've worked most with. You're able to, a woman can do it herself, put it in the tube, and if she's at a clinic where we're working with the breast and cervical cancer screening program, it is then put into a medium before being sent off for testing. And the FDA approval for HPV self-collection is for in-clinic at the moment, except for one test, which we'll get to in a minute. And so by in-clinic, that could be a clinic bathroom. It doesn't have to be an exam room. It could be in a mobile mammography unit in the bathroom in that unit. It could be at a workplace wellness center. But the way the FDA has approved this testing is for it to be done with some clinical oversight. But it allows for a lot of privacy, and as was mentioned earlier by Marie, women who are uncomfortable being screened by a man or by someone they know, or have had experience with sexual trauma, or are just want to multitask. You know, they're at the physician's office for a sick child, might as well just do my self-collect while I'm there. And it allows you to, you know, complete more than one objective while in clinic. Next. So these are the instructions that are provided for how to complete self-collection. I'm not going to go into the nitty-gritty about this, but it's just a simple rotation for 10 to 30 seconds in the vaginal cavity up to the line on the swab. And then the way the patient does it is they complete it in their private setting. It could even be, I know one clinic is doing it in the exam room with a medical assistant in the room, but their back turned. They put the swab in the canister and they hand it back to the medical assistant. Next. So HPV self-collection is just as sensitive and it's more sensitive than cytology alone, and it has comparable sensitivity than clinician collected. So HPV self-collection has been shown to be just as effective and strong at producing accurate results as clinician collected. And this is amazing because it allows a woman to do it in privacy. It allows for a lower cost clinic visit to complete the testing. Next. This is the slide I was thinking about earlier. So these are the tests that are approved right now is the first two, Cobas and OnClarity. They've been approved, I think, for almost 2 years, maybe a year and a half. And those are the two tests that are approved for in healthcare settings. The Abbott is under review. We expect it to be approved soon. And lastly, I think about maybe a year ago, 6 months ago, the Teal Health One was approved for self-collection at home. But the catch with the Teal One is it's a direct-to-consumer testing situation where you receive the test directly from Teal Health. And my understanding is $100 for those with insurance, and it can be between $300 and $500 for those without insurance. And so you are not integrated into a primary care setting if you use the Teal wand. You are receiving your results directly from the Teal company, and they, I believe they probably have resources to refer you, but it's a little bit of a separate process than the Roche and BD tests, which are included in testing within a primary care setting. And now for the breast and cervical cancer screening program, they're using Roche. Which one are you using, Marie? Roche and BD? Roche and BD. So those need to be done in a healthcare setting. Next. So we could see why this is beneficial. I mean, easy to perform, less embarrassment, no additional pain, private. The harms would be, if you have a patient with other health issues, they're not getting that pelvic exam. If you have a patient who maybe needs some additional attention for other reasons, they won't be getting that necessarily that in-person interaction. Furthermore, you could see some challenges where if a patient has a number of competing issues in their medical chart, where maybe it would make the most sense to have them come in. But to get our numbers higher than we are as the bottom quintile of the country for the Mountain West, this is a fabulous way to improve our cervical cancer screening rates. Next. So who is eligible? So you need to be eligible for primary HPV testing. And as I said earlier, for ACOG and U.S. Preventive Services Task Force, that is women and persons with a cervix age 30 to 65. You should have a clinician collected sample if you have a history of a prior abnormal pap test. You may want to be talking about your specific background or a history of cervical cancer screening. Furthermore, HIV positive or other immunosuppression, in utero DES exposure. DES was a drug that was used to prevent miscarriage but caused a lot of birth defects and has a high correlate with cervical cancer incidence and presence of other gynecological symptoms. Like, maybe if you're having some other sort of discomfort in the vaginal region, you would prefer to have that clinician collected screening test. Next. So before it used to be specific healthcare professionals who were trained in pelvic exams could do this, or had experience doing PAP and primary HPV testing. You'd have to have a specific appointment to complete that procedure and specialized office equipment, the forceps, or the stirrups rather. But after self-collection, we could have a medical assistant supporting the procedure with, a clinician supervising the whole clinic. It could be part of any appointment, lab, or radiology visit, and it can be in any privacy setting. Next. So these are the differences, and I think we touched on many of those, but the clinician collected really, it goes for the cervix. Self-collection goes for the vagina. Speculum is used with clinician collected. PCR test is run for genotyping with both settings for primary HPV. With the clinician collected, they can do pap cytology and dual stain on the same sample. So that is one other additional negative, is women who test positive with self-collect, then they have to follow up with either pap cytology or repeat testing. For clinician collected, patients need to return only for colposcopy. For self-collected, they return for 16 and 18 for colposcopy. Or if positive for other HPV, they need pap or dual stain, so they can return for pap instead of an additional HPV test. And then the screening intervals for clinician collected are 5 and self-collected are 3. I know this is going to be really confusing when we're rolling this out on the national level, but that's the way the guidelines were set. And primary HPV collection, as discussed in both of these columns, is more accurate than pap testing alone, cytology alone. Next. 1 in 10 patients will have a positive result, referred for colposcopy if 16 and 18, or pap if the other HPV types. The patient must return for speculum exam for dual stain or cytology testing if they have these types: 45, 33, 58, 31, 52, 35, 39, 30, 68, and 51. But this might be a little bit in the weeds for this group, but just know that there's a lot of HPV types that cause cancer. And we're getting so sophisticated that we're learning how to track and follow up with patients based on the types that they're positive for. And I think that's really exciting. That's precision medicine happening right here and now. Next. So insurance covers HPV self-collect in the way that it would cover primary HPV. We've been able to bill it using the same ICD-9 code. We've had no challenges in billing HPV self-collect to insurance in the work that we've been doing, which is super exciting too. Next slide. So there's going to be more abnormals, because if we have 10% positive, so we need to have a really tight referral system to get the patients who need a referred colposcopy or clinician collected pap appropriately treated. And then those who need additional follow-up care receive that treatment to lead to an earlier diagnosis. Next. So we have been running work in this area for about 1.5 years with, next slide, with 4 clinics in Utah, 3 community health centers, 2 in rural Utah, 1 in urban Utah that serves the unhoused. We are trying to look at how do we coach other clinics to do the same thing. So this is an implementation science project around the feasibility of rolling this out in diverse settings across the state of Utah. Next. Our partners have been phenomenal. They've helped us adapt some educational materials and videos to inform patients of this opportunity. And we have been pilot testing these and getting feedback on them. Next. We've also have these really neat HPV fact sheets for clinic distribution to help patients know where they should be going next, depending on a normal result or a positive result. And we're trying to relabel it as normal and abnormal because it can be confusing, because positive can sound good, but it's not necessarily good in this situation. It means need additional follow-up. So we've worked hard to try and adapt these materials and get feedback on how to improve them. Next. So far, we've done 262 kits in Utah. We have allowed for both home and in-clinic completion because this is an exploratory research-based project. So we've been able to work with the University of Washington to have tests that are completed at home, evaluated in their labs there, and they're treated the same as primary HPV collection done in clinic. we have had 48 abnormal results, about 20%. So when I see 48 abnormal results, and I know of those abnormal results, we've gotten 90 to 95% of those patients back in, I know we've done some good here. And we've actually hopefully prevented some precancers and cancer. And furthermore, we've allowed the women who've tested normal to have the peace of mind to know that they don't need another test for 3 years. And that's also some good. Next slide. So thank you so much for your time. And it was a pleasure to be here today. And if you're interested in doing work in this area, my team has received some funding to roll out this implementation science study in other locations across the Mountain West and pilot the integration of HPV self-collection into your clinical practice. Thank you so much.
Awesome. Awesome. Thank you so much, Dr. Kepka, and all of our speakers for being with us today and sharing expertise, your experiences, and the important work that you're doing to expand access to cancer screening and prevention. So to recap, we started off with hearing about the national burden of cancer, highlighting some new innovative ways for mobile screening and in-person screenings, community partnerships, and then exploring new opportunities for cervical cancer elimination. So we really hope that today's presentation showcased the many ways that we can bring care closer to communities and expand access to care. So with that, we are going to open up the floor for questions. One of my colleagues, Belem, is monitoring the chat. So if you do have a question, feel free to pop it in there, and then we will read them off for the next few minutes. And then at the same time, we just have a very quick poll for 3 questions about today's webinar. If you could answer, we would really appreciate it. So Belem, is there any questions in the chat right now that we can bring up to the speakers?
Yes, there is one question. Are mobile screenings available to all community members, regardless of legal status or insurance? If someone receives a positive result, what follow-up care options are available for those without insurance or without legal status? These are common barriers in the ACS community. I assume that's Alliance Community Services that's posing this question.
I can start with that. So in Utah, it doesn't matter legal status, whether or not you're here legally. They can be seen on all of our mobile mammogram units. And if they qualify for our program, we can cover them for their screening and diagnostic services. So if they're seen on a mobile mammogram van and need additional follow-up, then we will schedule them at one of the standalone facilities like an Intermountain or Huntsman and get their follow-up screening. If it turns to treatment, our program cannot cover that, but there is financial assistance through hospitals, as well as if they do qualify Medicaid, the Medicaid Treatment Act will pay for low income.
Awesome. Thank you, Marie.
And it's very similar here in Nevada. We can cover as well. And if they are in the breast and cervical program, oftentimes we can fast track them to Medicaid for treatment. Similarly, many of the facilities do have financial assistance. We also are able to help navigate people to follow-up care and financial resources. And as I mentioned, many of our providers have offered pro bono to follow up on some of the pop-ups that we've done. Definitely skin cancer, colonoscopy are 2 examples.
Great. I have Rocio wanting to ask a question. Leslie, is that okay if I allow her to ask her
Yes,
question?
of course.
Hi, friends. Yeah, so my question is, last year we were at Care Fair and it was really cool to see all the mammogram buses there. It looks like they brought the folks from the U, and Intermountain as well. Um, an issue that we encountered that was difficult to navigate was that a lot of times the folks that attend these kinds of events don't necessarily have a primary care provider that they can follow up with. And we had some barriers with one of the buses conducting the mammogram on somebody because she didn't have anybody that those results could be sent to. Um, the person was obviously following like procedure, but at the same time, this patient did not have a primary care provider, so that created some barriers there. Have you guys encountered similar things? How did you approach it? Do you have any advice with Care Fair coming up again in June this year? I'd love to get you guys' feedback.
So I'll start with that also. We help navigate the women there at the Care Fair and pay for the mammograms that for those who qualify onto the vans. What we try to do is if there is something that needs to follow up, is we try and get in touch with that client and match them up with one of our providers that we partner with and get them follow up through that. So they would see the results and follow that person. So then they're not only getting follow-up care for their mammogram, but they're also getting a primary care provider. So that's how we try and handle it with any of the mammogram vans.
Awesome.
And if
Thank
you
you.
find someone who's not matching up, we're always welcome to hear from you and help you with navigation.
Awesome.
Okay, we have a question for Carrie. Nevada, do you have any educational resources on using insurance for screening? We've identified that lack of knowledge as a barrier in Utah as well.
That is an excellent question, and it's something we've been discussing that we need to come up with, and perhaps some resources and education for the community in that regard, because that was one of the lessons we learned. So we don't have anything at this point, but I'm pretty sure Kristen, our communications director, is hot on that one. And we're happy to share anything that we come up with.
Thank you, Carrie. There are no other answers, or no other questions. Sorry, not answers.
Awesome. Great. Well, if you do have any questions, you are welcome to reach out to me and I can connect with the speakers. Speakers, thank you so much again for being with us today and for a great webinar. We'll be in touch and thank you all again for joining us today. We had a really great webinar and are looking forward for more opportunities to increase access to screenings and working together towards that goal. So thank you all again and thank you all for joining us here today.
Thank you.
Thank you.
Thanks so much.
Thanks, all.